All right. So this should look familiar to you. Can I? Oh, I can't. Yes. This should look familiar, right? Mm-hmm. This looks like the little black box on the monitoring equipment. Legit, because I just took a screenshot of it and saved it. So right here up at the top, this one is your heart tracing. How do I know? Because it says ECG right there. And right over here it says your pulse rate. No, that's something else. P is 62. The beats per minute is 67. Then we have the blood pressure, and we've got respiratory stuff and the O2 saturation, right? This person looks okie dokie. So an EKG or ECG is an electrocardiogram. What does that mean to us? We have no idea, lady. So this is a continuous monitoring. You'll see this on the little things. This is a paper EKG. All right. I'm not going to ask you what every little square is measured, but just so you know, every little square on here is, a certain time frame, so that we can say that this whole strip is 10 seconds. That's a 10-second monitoring of your heart. And literally an EKG strip is just a 10-second snapshot. It's 2.5 seconds from here, so this would be 5, 7.5, and 10. You get what I'm saying? A physician or somebody smarter than me can look at that and go, oh, okay, this is going on. And this takes the pictures throughout the different aspects of the heart and plops it on a paper. Okay? So that whole 10-second snapshot is on here so that a physician or a telemetry nurse or anybody, who's had special training can look at and see what may be going on with the heart. What we are concerned with is knowing the cardiac cycle. Now remember, or maybe you haven't gotten to the part in A&P where they're like, I need you to trace the drop of blood through the heart, where it goes into the lungs and out the whole 9 yards, right? We're not going to do that. But what you need to know is the cardiac cycle from first heartbeat to the end, because that's where things can get a little tricky. But baby steps, and I got this. So the cardiac cycle refers to the events that occur from the beginning of one ventricular contraction, which is systole, until the beginning of another. So the entire front to end. All right. So the ventricles fill with blood during rest, diastole, and eject the blood into the pulmonary artery and the aorta. But it has a lot of other complex events that occur electrically. So what you need to know are there's 2 types of principal cells, the working cardiac cells and the specialized neural conductive cells. The specialized cells include the sinoatrial node, the atrioventricular node, the bundle of His, and the Purkinje fibers. I say Purkinje. These cells originate in and transmit the electrical pulses across the heart and regulate the rhythm of the cardiac cycle. Okay, those are the little guys. And my little cat loves the heart. So here's where they are. Here's your SA node. It's on the atrium, sinoatrial node. Here is your AV node. It's on top of the ventricular. Here's your little bundle branches, because when they say there's a bundle branch blockage, that's where those are, right there and right there. Here's the Purkinje fibers. Those are enmeshed within the heart itself. And the bundle of His is somewhere in the back. So if cath lab is your thing, hearts, you got to know about the heart. But it's really quite easy once you get the hang of it and you see where things go and what's going on in there. So actual firing rates can be influenced by the autonomic nervous system. And that's when we get into the A and P of the sympathetic and the parasympathetic. Have we done that yet? No? Okay, great. Sympathetic nerves can increase activity or rate of cardiac impulses, whereas parasympathetic nerves slow the rate. So if you had a gun go off near you and your heart jumps, that's the fight or flight response, right? So which nervous system controlled that?
Sympathetic.
The sympathetic. The parasympathetic nerves slow the rate. That's you going, okay, there's no danger. Parasympathetic brings you back to homeostasis. Sympathetic, get you gone. Fight or flight. Okay? So the cardiac cycle begins with the SA node. We have to know that. It is the pacemaker of the heart. I think I put it in there several times. Abnormalities within the neural conduction system will adversely affect cardiac output. These abnormalities are called arrhythmias or dysrhythmias. Those words can be used synonymously. Some places call them arrhythmias, some places call them dysrhythmias. Doesn't matter. So, as we get into the nitty gritty, we got to understand the basic concept of how this happens. All right. All cell membranes are positively charged on their outer surface. Okay. Now, this is the wording of what we're learning: the depolarization and repolarization of the cardiac cell. This is just the wording part. This is called the action potential. And I don't know if you've heard that in A&P, but they'll be like, oh, what is the action potential of cell? Blah, blah, blah. Gotta wait. We're going to be good. Promise. Because I put it in the pictures, y'all, and it's great. Here is a cell. He is happy. He's chilling. He's positive on the outside, but he's negative on the inside, like all of us. He has potential to be bad, right? But he's trying to get right with himself. Somebody comes along and stimulates him. The cell changes from positive on the outside to knives out. He is just unhappy. That's called depolarization. You just changed the polarization of that cell. Well, you didn't, but the stimulation did. Then he gets mad, tries to force out those ions that made him negative in the first place because he's trying to get right with the Lord. Comes back to Zen. That is repolarization. Did that just make sense? I took a lot of time thinking about that, y'all. Because I was like, oh, that's it. If I can put it into pictures of a cell that's chilling positively on the outside, and these are all of your cells within your body. So now if you know when they say, hey, what's the action potential for blah, 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 neural cells, you go, oh, they're all positive until they get stimulation, and then they turn negative. Because action potential has a lot to do with all of our cells. What is controlling this is the sodium-potassium pump, which I know you've heard of, within the cardiac cells. Okay? So, these are the words for what I just said. When depolarization occurs, the myocardial cells are stimulated to contract. The depolarization is very short. This happens within milliseconds. Milliseconds. Very tiny. The reversal of the ion flow reestablishes a positive charge to the outside of the membrane. That is called repolarization, which returns the membrane to its resting potential. And that's when the myocardial cells relax. That whole process is what this is. And that looks vaguely familiar because that is almost what an EKG looks like, right? But this is the words, and I don't care. This is the voltage-gated potassium channels, leaves, the calcium opens, the potassium goes in, the sodium. This is why electrolytes are very important. And this is why if somebody is low in potassium or sodium or calcium, it can negatively affect their heart. You will get aberrant rates for people who have low potassium, high potassium, all these different kinds of things. Your body's trying to keep you in homeostasis, and your body will actually use different ions to create your heart to keep it trying to go, because it has different, it can use sodium, it can use potassium, it can use calcium, it can use any number of things. But once you're low on everything, there's nowhere to pull that from. See where I'm getting at? So then your heart starts suffering. So these are the words in step form. The resting cell membrane is positively charged on the outside and negative on the inside. Like that. After stimulation, the positive ions enter the cell and it reverses the polarity. This process continues until the entire cell membrane is depolarized, and then the ions return to the normal location and the cell repolarized to its normal resting potential. All right. That right there is this. This is the breakdown of the EKG itself. We have what is called the PR interval. It's just P to R. This is the P wave. This is the Q, the R, and the S. This all together is the QRS complex. And here is the ST segment. So from S to T. And then T is another wave at the bottom, and sometimes there's a little U wave. All right. This shows you what's happening. The atrial depolarization, the ventricular depolarization, and then the ventricular repolarization. All that happens so very quickly. I mean, just like that. So very quickly. And that's what keeps your heart going. All the time, 60 to 80 beats a minute, every day. So that electrical activity is what we measure in an EKG, all right? How this works, how's it going? You're like, how's it going? And then let's show you that. Because I only did 2 slideshows on this because I'm like, EKG number 2. I believe you. Did that make sense? Do you have any questions on that? No, that's awesome. I'm not going to get too hard and heavy into it. We do need to know how the electrical conductivity works, but we could get into some, it's in depth, y'all. There's some cardiologists that go to school for years and years and years to learn how the heart works. I do not. So the actual tracing itself is, so the electrical sequence is initiated by the sinoatrial node. It's the pacemaker of the heart. There are 8 physiological events listed for a cardiac cycle, but only 3 are observed on an EKG tracing. All right. The depolarization of the atrial muscle is the P wave. The depolarization of the ventricular muscle is the QRS complex. And then the repolarization is the T wave. All right. But are you a physician? No, not yet. It's not our job or our scope to determine what a particular issue a patient has. But we need to be aware of issues, problems, or sudden changes in condition. Therefore, we have to know just enough to be dangerous. Right? just enough to know what's going on. So what we do is we can look at something and go, is it regular? You just take a look at that. Does that all pretty much look the same? Yeah, pretty much looks the same. Probably a walkie-talkie looking good. He could have some stuff going on, but I don't care. I mean, looking regular right now, right? Are all of those complexes similar? Yeah. You don't have something suddenly dropping out or going too high. You look at the lines that it's creating and you go, yeah, that looks about similar. That looks about right. Looks pretty normal. I don't care that it should not exceed 0.12 seconds. That's not for me to know. I threw it in there just so that you know. If you get into cath lab and more heart-related stuff, you might be needed to know. But you're going to be taught all that. I'm not going to sit here and go, okay, on this little square at 0.12 seconds. No. You just need to know that complexes can vary in appearance depending on what's going on with a person's heart. If you have depolarizations that are occurring that are not coming from the sinoatrial node, perhaps it's damaged. Other nodes will try and back up for that. Like the AV node is a ventricular paced rhythm. It tries to keep the heart going. That's why you have backup systems on your heart. In case something happens, it's going to keep trying to keep going. Okay. And when we put in pacemakers, which we actually do x-rays for, you can watch them put in the whole pacemaker, and what we're doing is replacing the sinoatrial node. They put leads within the heart to keep it going. So it's actually pretty cool. What does that? That would be called an ectopic pacemaker. So we've heard the word ectopic, like an ectopic pregnancy, right? That just means it's not the normal one. It's not the normal thing. It's on the outside. It's something where it's not supposed to be. Still there. Does that make sense? Yeah, sure. If all the waves are similar and normal in shape, we can go, okay, looks like he's pretty good, right? Right. Is the rate normal? Now, these you will need to know. What bradycardia is and what tachycardia is. Bradycardia is below 60 beats a minute. Tachycardia is above 100 beats a minute. Okay. Do the waves and complexes proceed in a normal sequence? And you're like, yeah, okay. So the book actually shows you some different ones that I put in the words because they didn't bother. So this is like a normal sequence, okay? This right here would be bradycardia. Why? Because it took so long for the heart rate. And I'm going to tell you right now, all the equipment that I've ever seen or had, if you hit the button and it pops it out, it'll say how many beats per minute it was. I'm not going to sit here and go, okay, well, that was a 10-second thing. There was only 1, 2, 3, 4, 5. 5 in a 10-second thing. And for 60 seconds, that would be 5 times. I'm not doing that. Nobody cares. Okay, cool. Gotcha. This is really fast. Woo! So we know that that was a 10-second window. I'm going to go, okay, 1, 2, 3, 4, 5, 6, 7, 8, 9, 10. Something's going on with this fellow. Tachycardia. But it's not like crazy. It's not all over the place. We don't need to call a code. Okay? Here's some more tachycardia. Threw it in just for giggles. You will hear different words. You will hear different things that apply to hearts. And you're like, oh, okay. The ones where we start getting into and we have to start paying attention, sinus tachycardia is a normal thing. It's just a heart beating fast, but it's going through a normal sinus rhythm. All right. This one is where you start paying attention. This word right here is fibrillation. Do we know what fibrillation is? You've just heard about a defibrillator. Yeah. Fibrillation is where the heart muscle doesn't know what to do and is sitting there fluttering. There's no actual pacemaker shooting it off to make a normal rhythm. So if a fibrillation is happening, something in the heart is fluttering and it can't get its life together. So do you think if a heart muscle is fluttering that it can pump out all the blood that it needs to and perfuse normally? Right. That's a bad thing. Because once it starts fluttering, things can go sideways quick. Now, you can actually live a normal life with an atrial flutter. Some people just take medication for it because the medication will help settle your rhythm into place. I myself have this. I have premature ventricular contractions, was worked up for it the whole 9 yards. They don't know why. I just take medication. I can still feel my heart flutter sometimes, but it's a normal thing. Just happens to be normal for me. So not everything is a life and death problem with the heart. However, if you have a patient and they suddenly go sideways, and you see on the rhythm some things like this. What is asystole? Do we know what that is? A means, back to medical terminology, A means without. So systole means without. I appreciate the fact that you're reading off your notes. Yes. Mm-hmm. Without, it's not beating. This is a no heartbeat. This is a flat line. When you see the cool ER shows where they're like, oh, is it asystole and charge and that's a defibrillating event, y'all. This is a call me a code because we got some problem. And I kid you not, you can have a walkie-talkie who walks in this way and due to whatever, can walk out that way. Okay? You always have to be aware of your patient. They may have things going. We see patients like, every 5, 10, 15 minutes. We don't know their entire blessed history. They may be there for a knee x-ray, and suddenly they're going to have a stroke, or suddenly they're going to have a heart attack, or suddenly you put in an IV for a CT, and they're going to pass the hell out on you. One of the nursing instructors, God bless her, was telling me yesterday that she had one of her students, they were going over injections or whatever the heck it was, and one of them, and you can tell this on a patient, right? Something's just not quite there. They start to get this look. They don't engage when you're talking to them and you're like, hey, you good? And they just sort of phase out and then pass right the hell out and hit the floor. And you're like, oh, shoot. You've got to be aware of, and that's why I continually talk to people. Hey, what you doing? How you doing? Keep an eye on them. And this is how we're going to learn. If somebody's up at the bucky board and suddenly they have orthostatic hypotension, or they've been laying in a bed for the last 15 hours and suddenly stand up because they brought them down in a wheelchair because they thought it was great. Stand them up by the bucky board, and then all of a sudden they want to drop. And you were just standing there trying to put in the thing to the bucky board. They're like, oh, catch me. They won't tell you anything's going wrong. They won't say anything. Sometimes they don't have that chance. Has anybody ever passed out before?
No, but this lady almost yesterday.
And how was that? Did she sort of get a little weird and you can't really quite put your finger on it and so you good, fam? I ran into a little old lady coming up the other day. She had one of those walker wheelchair thingies. No, it's a little walker thing. And she suddenly slumped over it like this. And she was trying to get up the elevator and I'm all, ma'am, are you okay? And she's just like, yeah, I just feel really dizzy for a second. I was like, oh. I think we need to come sit down. She said, no, I just need to get up to wound care. I was like, well, I'm going to help you. Because this lady, God bless her, you never know what's going on. Maybe she forgot to take her blood pressure meds this morning. Maybe she didn't have a Coke this morning. Maybe she's diabetic and she needs something. People can go sideways very quickly. So it's up to us to make sure what's going on. Now, the chances that we are continuously monitoring a person are very slim. I'm going to say that the people that come down from CCU and ICU, they come down with their nurses, thank God, and they put them onto the CT table, and it's usually with a sheet full of stuff. And it includes the monitor, always and forever. Your patient should never, ever, ever be without a nurse if they're coming from CCU or ICU. Fantastic, good, because what are you going to do? Yeah, straight up, I'm like, I need a rapid and CT. Your nurses should come down and they are monitoring the patient with you. You need to be aware that if you are giving contrast material, you always have the potential for any interaction. How many of you people are allergic to anything? Hold straight. Who's allergic to anything? Grass, pet dander. I'm allergic to. Y'all aren't allergic to anything?
My kid, so we went down.
I thought you said my kids. I'm allergic to
Me too.
Same.
And we were on the road, and so my parents live, it's like 30 minutes from the hospital. And my kid was like scratching it out. I don't know.
You don't pay any attention
And
to
we
it.
got,
You're like,
we got
bud.
to my parents, and he had welts all over him. I'm like, oh my gosh, like what happened? And I think he's allergic to coconut. I don't know, but we're gonna take him to the allergist. But like, I was like, I need to go get some Benadryl because
You're too far
we're 30
away.
minutes from the hospital.
And what's going to happen? And that is what happens when people live out in sticks and they have a bee sting and they never knew they were. What's that old movie? My Girl.
Oh yeah.
Yeah.
Stung by the bee.
She got stung by the bee and died.
Yeah, and then.
And now I'm horrifying you.
You're freaking out. And I'm like, dude, it's different.
I was just gonna watch
He's
that
like, you work in
yesterday.
healthcare. It's different when it's your children than it's with somebody else.
Yeah, this is true. But it's also, something that we have to be aware of. If we are putting something into a patient, we don't know how they're going to react. And that is true for any medication that nurse has given them within the past God knows how long. They can have an allergic reaction to anything at any moment in time. I will tell you my story. I carry an EpiPen and there is one in my purse in case I ever hit the floor. Okay.
Show us.
Huh?
Show us.
Show us?
What are you allergic to?
You don't believe it?
I'll get there.
Our EpiPen.
Yeah, you don't believe me?
Oh, no, you don't have to. I thought your bag was here.
Nope.
What if we?
Steven.
Oh, really? All the papers get thrown.
You're like, show me. She goes and eats something she's allergic to.
She started popping it.
I'm tired of this shit.
Damn, I feel bad now.
Whatever.
We're on recording.
Okay, I don't have it. But it's in my other purse. Oh wait, maybe it is in here. Because I do carry it with me.
Steven's about to call you out for being a liar.
I know, right? Or maybe it's in the car. Anyways, it's a big, it's like this size. And it's orange. Okay, that's an EpiPen size. But, so I'm allergic to some weird stuff, but something happened where I get angioedema. And that was, your lips started swelling up, your tongue started swelling up. And then one day I couldn't make the connection what I was allergic to until I did, through no fault of my own. The emergencies were 20. So it comes to find out I'm allergic to ibuprofen and NSAIDs. I had taken an ibuprofen for a headache. And then all of a sudden, I felt my hands, the palms of my hands got itchy and red. And then my face, you can feel it. It's a mast cell reaction. Okay, you can feel it. Has anybody ever drank the vitamin B5 shots? You people have not. Anyways, if you drink those 5-hour energy drinks real fast, it gives you what's called a niacin rush. And it's just the chemical of the B5 that's flushing through your body, and you feel like hot from the inside out. That's what it felt like. And then, yeah, well, then I couldn't breathe. And I had enough common sense. My kids were there. That was great. To call 911 and tell them where I was, but I was talking in a whisper by then. I was like, I can't breathe. And I fell to the floor. And I could hear everything that was going on around me, and I could hear the ambulance coming. I could hear my kids, Mom, what's going on? That is terrifying, y'all. So, Dr. Rao is a very nice, allergy doctor, and he was like, oh yeah, girl, we need to get you some evidence. But, you good?
But she was dying for like 20 minutes.
I was giving you a heartwarming story about my life.
Get to the middle. That's gonna be our sick row.
Oh, okay.
Keep going, get to the middle.
But this brings me to this point. You never know when an emergency will happen. Can you plan them? Nope. Can you drive to work every day and nothing happened for 6 years and then one day, car accident? I am so sorry. I am facing you with the realities of life. I bought a Powerball ticket. Did I win? No, I have better chances of getting hit by lightning today.
Oh yeah.
Yeah. Today,
Yeah,
it's like
Ronald
bright
looked
and
up the
sunny.
chances. He's like, yeah, you could play it for like 70 years.
Yeah, I know. I was like, I'm just contributing to the cause for somebody else to be, a rich person. So we have to be aware of sudden changes in somebody's status. Because even if they just fall out on the floor, what are we going to do? Are we going to run around and go, wee-doo, wee-doo, wee? Because that's adorable, but it is ineffective. All right. We're healthcare professionals now, y'all. Congratulations. The general public is going to look to you to know what the hell to do. Look to you. And you cannot be that person. Yeah. Tap out.
Be like,
No, you can't be that person who's like, I'm gonna go over here and look busy like I know y'all do in clinicals. Is you hear Brandon coming around and you're like,
no,
shit.
when we hear Kelly come.
Yeah, when you hear Kelly, and that's they hear my shoes and they're like, oh, Tabitha's here. Let me go talk to her about this. I was like, I'm gonna wear sneakers. I had a pen. Oh well. So we can't be that person who doesn't know what to do. Because we can be in a hospital picking up a patient out of room 304 and they are blue. And then what are you supposed to do? Somebody please tell me, because I know y'all went over this in orientation. Yes, Stephen. Look back there. Tell them.
Tell us, Stephen. Tell us what we're supposed to do.
Call a code.
Do you call it
Come on,
code?
Steven.
Yes, you call a
She's
code.
dead now.
Yeah. She's dead now. No. So legitimately, and I don't know if I have told you the story, but maybe I have. We had some transporters take a person to CT alive and take them back up to their room alive and put them back in their bed alive. And something happened between that point and then the next point where the family was in there and suddenly he was not alive. Because this person wasn't on telemetry. Well, no, I think they were on telemetry. But telemetry is not continuously monitored in the room. It's monitored at the unit clerk, the big nursing station, right? Mm-hmm. Somebody's always watching something in telemetry. And Come to find out after the investigation, it was the transporters who didn't put oxygen back on the patient. That's what they tried to say. But actually he wasn't supposed to be on oxygen. I'm like, that order was discontinued hours ago. So you can't really blame that. They were trying to blame the transporters. See what I'm getting at? This is why people in the quality and risk management department are very skilled at their job at picking apart what happened in the chart and making sure people know how to do their jobs. So come to find out, it was simply a tragic event where his heart decided to give out after coming back up from CT. But the family's perception of that was, you killed my daddy and you didn't put the oxygen back on him. You didn't do this. You didn't do that. And they will create a firestorm. Because what does anybody want to do whenever they feel that they have been wronged?
Sue.
And they gonna talk about it on Google, Facebook, TikTok, YouTube, any public platform that they can, which is their right, yes. However, here's the problem with misconceptions and what actually happened. Will they ever believe what actually happened? No. You could face these people with enough truth and enough reports and this, that, and the other saying, this is how your dad died. It was because of X, Y, Z, which actually had nothing to do with with why he was there.
Was this in this area?
I cannot confirm or deny.
So what
What?
happened? What happened to him?
What did it? Actually, he recovered. I think code blue.
So he wasn't dead.
No, he wasn't dead. But he was dead up until that point.
He was in for a little bit.
He was dead for a little bit. But they had to call a code. They had to get everything involved. They had to resuscitate him and move him to the CCU, et cetera, et cetera, et cetera. But this can show you how, a tragic line of events can be perceived. And then even, Lord, with the conspiracy theories, people will come out and believe, oh, the hospital's just covering it all up. I kid you not. I mean, everybody wants to believe that nobody actually has their best interests at heart. And even when confronted with enough evidence, there are some people that you will never unconvince otherwise. And I accept that. I get that. I can't change your religion, can I? I can't change your religion. Nope. I can't change your religion. And I'm not even going to try. Because it's your right to believe whatever you want to believe. So here's the sticky widget. We have to recognize what's going on and intervene as quickly as possible. Because otherwise they'll be like, I saw that lady in the gray scrubs and she walked away from my grandma as she was, I kid you not, yeah. She walked away from my grandma and didn't help her. She saw her fall. People in Walmart get this. I kid you not, and they'll come back at you. They'll be like, that lady with the brown hair. Oh, well, which one? I don't know. She was wearing gray scrubs. That's why you wear scrubs for your department, so that they can single you out. Yeah. It's when patients get a little, I always back that up because I did have some gentleman who called me what was it?
The C word?
Yeah, close. Something about a woke precious snowflake or something like that. Because he wanted to say that black lady came in here and did X, Y, Z. And I was like, excuse me, sir, she is an employee of this hospital and she has a name. Well, I didn't get her. Not my problem. You can describe people any other way. Snap them back to reality. I'm like, no. You want to front on me? I'll front right back, but I'll be very polite about it. Because that's the reality, is somebody is going to say that person right there and point it. It doesn't even matter if she had nothing to do with it. People want straws to grab at, and they will grab at anything. And in the moment of a situation, and you've been in an accident before, the world around you shifts. And things that you see may not be the entire truth. If you're flipping your car 3 times in a ditch, are you counting 1, 2, 3? And you're like, I did it 3 times. But I'm like, how do people come out of these accidents and be like, I rolled my Jeep 3 times? I'm like, you came in comatose, so how do you know that? Oh, well, somebody else told me. Oh, did we get that on YouTube? Because I'm going to count and verify. They seem to be proud of these facts. Like, okay. But anyways,
I'm gonna change your name in my phone to Snowflake.
woke.
Hope so.
Not if you want to pass, you won't.
Woke
I am a woke snowflake. Here is the reality of the situation we're living in. What year? 2023. And there are some folks still living back in the 1800s. And I'm like, y'all, no, we're not about that life. Priorities. We have to know what the priority is. ABCs. We all learned CPR, right? ABC. Airway, breathing, circulation. I have always said if air goes in and out, blood goes round and round. Any deviation from those two and you have a problem. You can keep pumping air on a person. You don't even have to do mouth-to-mouth CPR due to physics. Yes. You can just keep pumping on that chest, those machines. Have you seen the machines that automatically do the CPR?
Yes.
Yeah, those are pretty awesome, right?
But it's scary. Like when
It is
they're running
scary.
in and you see that on them, and it's like kind of. It's not like loud, but it's
Yes,
like it's loud.
it's overwhelming,
Yeah.
especially if you've never seen it before and you're like, oh, stars and goddess, what are you doing to my grandpa? You see what I'm getting at? They're going to go, you put, C3PO on my granddad, try to do CPR. I was like, we try to stay alive. But our priorities are always making sure they have an open airway. Number 1. Okay? Control bleeding. Somebody suddenly starts spurting out something, get something and put over it. Just that simple. Don't be like, oh, not my job. Not my job. You want to say, where's the nurse? No, we have access. I don't care if it's a towel. I don't care if it's a hand. I don't care. Somebody is spurting out some red blood. You need to do something about it. And plus call someone. We need to take measures to prevent or treat shock. Shock can happen at any moment in time. We'll get to shock. It's great. We attend to the wounds or fractures. So the fractures, as X-ray techs, pretty awesome. All right? They hurt. That is why we have to take care in minimizing hurting this patient anymore. That is why we have to take care in being able to know that I'm going to do your elbow this way because I can see the bones kind of coming out this way. And I can't say, oh honey, that's broken. But I can be like, we're gonna have a difficult time. Okay. I am preparing you for what's going to happen. All right. We minimize what we're trying to do to the patient, and you will have the skills and the knowledge to go, I can lay you down and do XYZ. I can stand you up against the Bucky board. Look, I try to clean that. And I can do it like this. Would that make you feel better? We can learn the tips and the tricks to figure out how to minimize hurting our patients even more. Okay. Provide emotional support. Holy hell. I'd be like, Amy, you're having a bad day today. Would you like a hug? All right, cool. Moving along. Some of our patients may have Alzheimer's. Some of our patients may be very teeny tiny people. Some of our patients may have cancer. Some of our patients may have just gotten a diagnosis and they're overwhelmed and they don't know how to deal with it because this is going to be a long, drawn out road for them. And they don't know. Just like your first day of school, you were scared. Every single one of you put that into your discussion. You were scared that you didn't know what was going to happen. The fear of the unknown is what that is. As long as you acknowledge it, you make your peace with it, and you say, this is how I'm going to proceed, and I am not going to be afraid anymore. Are you scared now?
Yes.
Okay, I appreciate your honesty. But you've become familiar with the process. You've learned what to do. You've learned not to take your phones out in the middle of clinicals.
Who did
Because
that?
I straight up, Stephen, I straight up, how many times did I warn you guys? I was like, they're gonna. It's like, they're gonna. And they will call me, they will text me, they will email me and try and get you in trouble. I know. Stuff is real. Anyways, it doesn't matter how much I warn you, I guess sometimes life is the best lesson. But provide emotional support to your people. Even if, somebody's having a moment and you're like, is there anything I can do to help? Would you like a blanket? You are the best you could be the best person that they see today. They may be going back to a domestic violence situation that you have no control over. That's always what I have told any of my new hires, new graduates. I'm like, you know what? We're going into nursing homes where they don't get out of bed. Be the nicest person that they see today, because I know damn well how some of those people get treated. And I'd be like, can I get you anything? Do you need some water? I'll bring you some Twinkies and Ho-Hos. I don't even care if you got diabetes because you're 87 and you deserve it. Let's not do that. But I'm just saying, whatever I could do for this patient, I would. Can I get you another pillow? Can I help you up in your bed? Where's your buzzer so that you can call this person who isn't going to come and find you for the next 4 hours? It makes them feel better, right? Provide emotional support to your folks. Continually reevaluate and follow up appropriately. Now, in a hospital situation, I don't think you're going to be sitting here taking a blood pressure every 15 minutes on your patient. However, we have the equipment in the room in order to do that, right? You've seen a blood pressure monitor on the wall. It doesn't matter if you're in CT or if you're in X-ray room 1, or I think they even have them over here, blah, 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 blah. So in case you're a radiologist, you ever have a reaction, you ever have a anaphylactic reaction, your radiologist may come in there and be like, here's what I need, and he will start barking out orders. You've never seen this. He'll be like, okay, I need you to take a blood pressure every 15 minutes, and they will continually monitor the patient. He may want a whole set of vitals every 15 minutes for an hour, 2 hours after the reaction, because they have a cocktail of medication that they're giving this patient to make sure that they do not die. All right? We have to ensure the continuous monitoring so that we can try and track. Continuous monitoring, vital signs were within normal limits for a period of 2 hours after this reaction. Why? Because all that stuff gets charted. We're not just going to throw it away and be like, oh, well, glad you had a reaction, seems you're okay, and then send you home and just let you live your life, because something can happen once you go home. You can actually have an allergic reaction for hours after being given a medication. Fun times. So you need to know, as an X-ray tech, where the crash cart is. You've seen these handy dandy little, and did you have the whole orientation on where is the crash cart? Was it room 3? I can't remember. Anyways, there is a crash cart everywhere, right? Nod your head. Yes, there is. You need to know what is on that crash cart. This guy right here, what do we think this is? Is there... It is actually, I call it a Zoll. There are different brands, okay? It is the AED defibrillator. All right, that is on every single crash cart. This should be on every single crash cart as well. Plus, there is a bag in every single room. That is the airway bag. Inside that, I guess I can keep going. Let's go back. Inside that bag, you will find that blue ambu bag. Okay. There is oxygen tubing, and I'll get to the other thing later. So on these crash carts, I want you to be aware. There is a lock up here or wherever they stick them that should be locked at all times. If you see that this lock is broken, I need you to alert somebody immediately. Okay? Why is that? Because we have some medications on this chart, on this crash cart. Now, the crash cart is, and I'm going to call it clean, the crash cart is full and stocked and locked, and it is put back into its place until the next use. So whenever there is a code and somebody cracks open the crash cart, that lock is broken. That crash cart is not clean, it is not full, and pharmacy is usually the one responsible for coming and getting that crash cart and replacing it with a clean crash cart. Does that make sense? Because you can't use a crash cart that doesn't have all your epi in it. I guarantee you that would be a bad time. So there is a whole process in the hospital for replacing crash carts. However, I want you to be aware, if you see a crash cart that has had its lock broken, it has to be replaced immediately, because guarantee you, let's not set up Murphy's Law to have the next patient need to have something in that crash cart. Yeah. So we have a whole bunch of drugs that are commonly found on a crash cart. Do I need you to know what these are? You're welcome. I will tell you the ones that you will be familiar with is Benadryl. Diphenhydramine is Benadryl, the little pink pills that you can buy at Walgreens. However, that is in IV form. All right. The other ones for allergic reaction is the dexamethasone and the norepinephrine. So usually what happens is whenever there's a code called, nurses and doctors come rushing over because are you able to give medications?
Mm-mm.
No. Then why do I have a crash cart? Because they ain't coming with their own crash cart. The crash cart should be where your patient is currently having a problem. So they do not bring their little cart. They have all their drugs on the crash cart, ready to go. Okay? So we've seen these in every room, right? Nod your heads, yes. In every room is an ambu bag, the oxygen tubing, and I'm going to again tell you, these little green things, do we know what they are yet? You can read up here. A Christmas tree. I guarantee you somebody will ask for a Christmas tree and you won't know what the hell they're talking about. A Christmas tree is just this little green adapter for the stupid, put it on the end of the oxygen tube for the portable oxygen tanks. You're welcome. Yes? No? Okay, great. So, what else do we have in the room? We have suction, that's on the wall, and we have oxygen. If somebody is coming down and they're being transported at 6 liters, we are going to hook them up to the wall oxygen at 6 liters. We are not going to turn it down. We're not going to turn it up, because are we able to dispense oxygen? No. We cannot change what that patient is currently on. Okay? A doctor, if somebody's having a reaction, he goes, bump them up to 8 or 10. I am following a doctor's order to do that. Okay? Does that make sense? But we're not changing anything. This section is for some, let's get into it. The section can be used for barium studies. Say we have somebody who is vomiting everywhere and it's just not pretty. We can suction out the barium. Okay. The Yonkers. Oh, I should have put a picture of that. The Yonkers is the big long thing that they use to suction with. So now you can go into the barium kitchen and go, oh, now I know what a Yonkers is. Now I know what this is. And become familiar with that stuff, because I guarantee you somebody's going to go, Stephen, I want you to, oh, you're not Stephen. Stephen, I want you to go get a Yonkers real quick because they're having a crash and whatever. I meant, he was following us. Anyways, so have we seen portable oxygen tanks yet?
Mm-hmm.
Like, yeah. They fall over, they're really damn noisy, and you're like, oh God, it's gonna blow. Yeah. So right here is where we change the flow rate. And right here is where you stick the oxygen tubing. But sometimes you need to have a key to make that thing work. Nobody tells you this when you get into healthcare, and you're like, so what going on? I'm just like, oh, it's whatever. I cannot tell you. So I don't know if you can actually see that. So this was my life, y'all, as a mobile x-ray tech. I'd get an order for a chest x-ray at nursing home XYZ in Midland. And I have to confirm the order and say, okay, so why am I here? Oh, well, they're having shortness of breath and low O2 sats. Okay, cool. What are we satting at? Oh, 85. And I go into their room, and the oxygen tank is empty. In my career of 15 years, I cannot count how many times that has happened. And this is why I'm telling you to be aware of what is going on with your patient. Maybe they just came from their house and they actually have no oxygen. The oxygen shipment didn't come in. I actually heard of people who died in the snowstorm in 2021 going out to get their oxygen out of the truck because they had no way to have the oxygen concentrator work when the power's off. Died in the cold. These are the things that we have to think about whenever the power goes out, but some people don't. Okay, some people come to the hospital because they are out of oxygen, and it's Sunday and Rotec is closed, or whatever oxygen provider out there is closed. Always make sure your patient is actually getting some oxygen. That's a no-brainer. I say that. But I've seen it too often where, my patient, I'm just like, so, you call me for a stat chest x-ray, however their oxygen's low, and I think that'd probably help you out some. I mean, I'm not a doctor, but.
Who's the department that's supposed to refill those?
It goes through, not maintenance, but EBS. Because the oxygen tanks that get filled by Liquid Q are usually those big ones that are on the outside of the hospital, right? And that's for your internal wall-to-wall oxygen. Now, if you're talking about these guys, the company will come and pick up all the empty ones and replace them with fresh ones. And it's like the linen service at the hospital. But for private people, it's usually like Rotec or I can't remember. I think there's one other company in Midland, Odessa that does it. But you literally rely on one company to bring you oxygen. It's like propane. There's several propane providers. But if you can only get gas from one gas station in Midland and it's always full.
Like in Fort Stockton, all of them are empty in the churches.
Crazy. Man, I could make a side hustle now.
Yeah.
And that's the problem. There's a lot of rural people who may live outside of the delivery area for certain things. Oxygen is one of them. You need to know this. You need to write it down. You need to at least take a look and say, oh, Tabitha told me. Yep, wake up.
Mm-hmm.
A portable oxygen tank cannot go near the MRI machine.
Why is that, Tabitha?
Well, you're welcome, Stephen. That is an oxygen tank. That is an oxygen tank. That is an oxygen tank. And not only that, but, I remember this story when this happened. Yeah.
Oh my gosh.
You would think. But that oxygen tank, and they bounce around. Magnets do not discriminate. Okay? They do not care that you have the best intentions. They do not care who is in that magnet. A magnet is a magnet.
This is a lot of the nurses like have no clue about what, like they know, but they don't know what exactly you can and can't in there. And like, I feel like they should get.
I feel like they should get MRI training every time that they are hired, which they do, which you went over with all of those PowerPoint slides with Sherry Laughlin, correct? And I believe that every X-ray tech or every student should get a more in-depth, which you will, more in-depth training as far as MRI and MRI safety before it happens. However, this leads to my next thing that could be a thing. Do you think a code can be ran with a patient in the MRI machine? No. How many times has there been a code in MRI because A, the patient's claustrophobic, B, they got some claustrophobia medicine, C, they flatlined, whatever happened, and then people start running because they, in their brains, have, I've got to get to that code. But somebody's got to stop them.
Their badge is going to be flagged.
Yeah, not only the badges, but they usually have scissors in their pockets. They usually have, any number of things in their pockets. Because I know nurses and I know doctors and they wander around. It's like disarming China. They've got some EMT shears over here and they're like, all kinds of crap just be coming out of their cargo pants. And we got to stop them. So the fastest way, and you'll see the tech, and I pray that you never have to see a code, an MRI tech do this. They'll run in and they'll pull out that table and somebody goes and gets the PVC or the MRI safe table. And you pull that person over and then you shove them through the hallway. Because you can run a code in the hallway, but you can't run a code in the MRI machine. Okay? So you must always be alert for every patient because a patient can decline very quickly. And you have to be aware of ever-changing conditions because your patient may need a code. I've called a code on, we had a young man, he was like 17, 16, whatever, and he was there for a joint injection. Joint injections are not nice things, okay? It was a joint injection for an MRI, but, they know that they're getting a needle into their joint. I think it was his shoulder. And to do this, we tell them you have to be NPO like 8 hours before so you don't go vomiting everywhere. Or whatever the conditions were. But he was, I don't know if he was working himself up, but something was going sideways. And he was like, I just happened to be taking another patient out of the waiting room. And he was just like, ma'am, I don't feel good. Please tell me more. Why? How do you not feel good? He's like, I just don't feel good. And he started getting that look. And I don't know if you've ever seen anybody who got that look, but they start turning white. They start turning white like a piece of paper. I've seen gray people. I've seen green people. And it doesn't matter what color they turn. I'm like, oh, all right, cool. Let's come lay down. We had a little holding area. I'm like, let's come lay down. Let's go find you something. He, I think, was having he hadn't had anything to eat and he was having hypoglycemia. And he just had never felt that sugar bottom out. And I don't know if you've ever felt it before where you're just like, something's not right. And they just needed a little bit of food, right? But do we know that? But I called rapid on him. So that way nurses can come in and assess him, evaluate him, do his blood pressure. Blood pressure a little low, but they were like, it's all good. Give him some sugar. Give him some dextrose. It's not my determination what's wrong with him. I just know something's wrong. And I do not want him to A, vomit on my floor, and B, I don't want him to die. I mean, what if he was having a syncopal episode? What if he has undiagnosed epilepsy? I had a young lady who was 8 years old. She had epilepsy. They didn't know why, but she would just go into seizures randomly, and you just had to hold her. And it couldn't be controlled with medication. It couldn't be controlled with anything. So it was like, they were all, just be aware, she's probably going to have a seizure. I'm like, oh, okay. So how do we best prepare for that? Ask parents, be like, so what do we got to do? They're like, you just let her have a seizure. It takes about 5 minutes, and then she goes on. But it can happen at any moment in time. And I'm like, oh. So people have some things going on, you know?
I hate hearing stuff like that.
Huh?
So I hate hearing stuff like that. Like, it makes me so thankful that my babies are healthy.
And there you go. But that's the realization of the matter is there's people in the world that it may be not so much for. So we'll start going through emergencies. I don't know why the book did this, but we'll just go through some things. You may get a person who's had a head injury, fell off a bowl, fell and hit their head, the little viejita who slipped and fell in her kitchen, all these kinds of things. I always go back to the AO times 4. Some people abbreviate that ANO, alert and oriented times 4. If I can talk to you and you're making sense, cool. If I talk to you and you're suddenly, talking to me about Harry Potter and wizards and some rando stuff, I'll be like, hey, so do you remember what day it was? And they may just, so we have to take this seriously. A head injury can go sideways very quickly. Now, hopefully they've been evaluated in the ER, and the time you see them, you're doing a CT head. That is where they are evaluating the head injury. Am I right? Yeah. You don't know what's up in that noggin yet. They can have fractures, subdural hematoma, subarachnoid hematoma. The whole left side of the brain could be gone because they had a surgery. I don't know. But we have to be aware that something could happen. Shock is important to know. I put it in yellow. There is actually several different kinds of shock, but the ones that we need to be aware of: hypovolemic shock, cardiogenic shock, neurogenic shock, and vasogenic shock. So the people who pass out when they see a needle, it's actually a form of shock. Just nothing that really, it's okay. So we are most likely to encounter the hypovolemic shock or the anaphylactic shock, which is a special type of vasogenic shock. And we have to be aware of what's going on, all right? So anaphylaxis, we talked to this a little bit, but you need to be aware, in general, the longer it takes for a reaction to develop, the less severe it is. This is not a hard and fast rule. Anybody can become allergic to anything at any moment in time. Period, end of story. You could be drinking whipped cream all your life and Starbucks is great, and then tomorrow you bust out and you're just like, what? Rash from head to toe. You got to do this whole, well, let's figure out what I ate, let's try it. People didn't know that they were allergic to wheat germ, and now celiac disease is a thing. Everybody in the world is like, oh yeah, you can be allergic to wheat. Lactose intolerance, same thing. Yeah, we're allergic to milk, it's great. So there is big reactions and then there are mild reactions. Mild reactions, Usually the radiologist will tell the patient, or we'll give them some Benadryl and say, hey, just monitor yourself. Looks like a low reaction. But you need to tell, and then we'll tell people from now on that you have an allergic reaction to contrast, because the next time that they get contrast, it will be double and it will be worse. I did not know that I was having reactions to ibuprofen, because you're just like, oh, I'll take ibuprofen for some period pain or a headache or whatever. I was building up reactions and I just didn't connect the dots until one day it's like, nah, you're going to die today. That can happen with anything. Okay, so let's not be in a bubble and think it'll never happen. It can happen with anything. Strawberries, you're like, lemons, whatever you like, you'll get allergic to it. Diabetic crises are something that we need to be aware of too. Hypoglycemia. Hypo means below. But why did I say which excessive insulin is present? I took it out of the book, but why is this a thing? Does anybody have diabetes? Know somebody with diabetes? We understand how diabetes works. I'm a diabetes educator, so guess what we're going to learn about? You like diabetes? No. Hypoglycemia, excessive insulin. If you replace excessive insulin with just knowing low sugar, it's because the insulin is needed to get into the cells, right? If you have too much insulin and not enough sugar to make that homeostasis happen, then you can't get sugar into your cells, right? So hypoglycemia is where, people are like, oh, I haven't eaten yet, I feel like crap, blah, 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 blah. And even people who are athletic runners, people who play football, they'll be like, oh, you got to carb up the night before, blah, 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 blah. So you have that sugar in your body so you can use it. Hyperglycemia is the condition of excess sugar in the blood and is typically associated with diabetes. And it develops gradually. You don't just get diabetes in a day. What? But you'll have these people who go to the doctor. My doctor says I got diabetes. I've never had diabetes before. He doesn't know what he's talking about. Bullshit. There's a whole way that we have to diagnose diabetes, and you have to pop positive on so many tests and have an A1C of this and before they can give you that diagnosis. But people deny it, don't they? Hell yeah, they deny it. As they eat a bucket of chicken and go, I have no idea what he's talking about. My doctor was stupid. Harvard-educated physicians, whatever. We need to be aware of respiratory distress and respiratory arrest. Asthma. Who has asthma? Who's got kids with asthma? I have asthma. Asthma is an allergy, like in your lungs. If you become exposed to something that you are allergic to, that is the reaction that is happening within your lungs, if that makes sense. Yeah. And you can have something induced asthma, like dust-induced asthma. What do you get asthma for? Cedar. Oh, you have cedar allergies. High five. Never moved to Austin.
I know. Whenever I was down there, I was so sick all the time.
Yeah. I lived in Austin for 2 years. I was like, this is stuff.
Steroid shots all the time.
Everywhere. Cedar fever is a real thing, but it's actually an asthmatic reaction to cedar. I have mold-induced allergies. I lived in Washington State for 5 years, where mold grows on everything. It will grow on you if you stand still too long. No kidding. I have never lived in some place. It's like the same in Hawaii. It's a very tropical place, and just mold is everywhere. And I'm like, what? And they're like, yeah, that seems you're allergic to mold. I'm like, oh, yeah, guess I'm gonna have to move. We also need to be aware of choking and choking hazards. We'll go over the Heimlich maneuver in lab. I don't know what people are choking on, but whatever. Like, you eating that chicken before you're burying it? Props. No. And then, of course, the cardiac arrest. This is where we call a code. We go get the crash cart. Okay? But we got to know the signs and symptoms. I'm more worried about cerebrovascular accidents. And on your badge, does it say the B fast? What you have to be aware of for anybody who's having a stroke? Like facial drooping. One side of the face starts drooping. Arm drooping. One side of the body starts drooping. You start slurring your words. Anybody can have a stroke at any moment in time. What better place to have it than right there in the hospital than sitting there at work and going, oh, I don't know what the hell's going on, but yeah, it'll be fine. It'll work itself out. 45 minutes later, it hasn't. 3 hours later, you're like, it still hasn't gone away. But here's the problem. You have a golden hour into which to get a certain drug if you have a certain kind of stroke. And that's why we try to ensure that your door to CT time is less than 15 minutes. They can actually call the ambulance in and say, I have a suspected stroke, and clear the CT, and the ambulance can put that patient on the CT scanner and they can scan that fast. Because they need to have a report done within 30 minutes, I believe. I had a badge that had all this on it. 30 minutes, I believe, because these are all national standards that we are trying to push. We are trying to reduce the amount of strokes and stroke damage that it causes people. But man, if they don't come in, we can't help them. So if you see somebody who's like, I think we're having some issues, Mom. I think we need to get you to the hospital. And they'll be, I guarantee you, they'll be like, no, I'm fine.
Oh my God.
I'll be like, no, I'm fine. I'll be like, nope, I'm pulling my card now.
They just want already.
I'm pulling my card now because you can do this as a healthcare worker. I am pulling my card and we are going, this is my what do you call it, card? You're going to listen to me card. We're pulling the card and I'm not going to listen to it, but you're going to the hospital because I've been trained to assess for at least stroke symptoms. Make sense? Yeah. There's all these other minor emergencies and I know it sucks. But here's the one that you need to be aware of. Guess what? Everybody throws up. Guess what happens when they're sick? They're still going to throw up. Nausea and vomiting is a big deal. And if you didn't know it, I'm telling you now. Then you can try this and see if it works. And you can try it at home. Take an alcohol swab.
Take a what?
Oh no, it does work.
No, this has actually been studied and proven, and they have allowed EMTs to use this on the back of the rig. The little alcohol wipies, the little 2x2s, rub it on the back of their hand and say sniff it.
Mm-hmm.
Guarantee it. Works on pregnant women, works on anybody who's got a little bit of nausea. I actually have some in I have an EMT bag at home. So I keep that stuff in my car. I'm like, you feeling sick? Shh. Smell it. I don't know how it works. I don't know why it works. But it does work. Studies have proven it. Do it for your patients because you know what? I don't have to be a doctor to wipe some alcohol on somebody. Hell yeah.
They're like, how did you do that?
Magic, yo. And that's what I tell them. I'm like, magic. If you have a nosebleed, this is seldom life-threatening. However, it can happen. Vertigo and syncope. That's where you get dizzy and you feel like you're gonna faint. So if somebody tells you that they feel dizzy, what are you going to tell them?
Damn.
No. They're like, bye. No. I immediately want them to sit.
You close your eyes.
Sit your ass. I'll even go get them a washcloth and be like, sit, stay. Let's go get a washcloth. Let's put it over your head. Let's find out what's going on. I do not want them to faint on me.
You're all my sons.
Seizures. This is frightening. If you've never experienced a seizure or had someone near you do it, holy crap, because you cannot control that. Please do not shove anything in their mouth, especially your finger. They will bite it off. Do not shove anything in anybody's mouth. Period, end of story. But here's what will happen is sometimes they have an aura. And an aura is just this prodromal feeling that comes over them. And they go, I think I'm fixing to have a seizure. Or they will say, I'm having an aura and I need to go sit down. And this is what dogs have been trained to sense as well for people who are epileptic. And they will go get their person and make them sit down before they have a seizure. It's actually pretty awesome. So what we should do is we have to prevent that patient from injury, okay? I've been involved with this seizure before, and it is not pretty, especially in a small room. And the best I could do was put myself in between here was the wall and here was the bed. Patient was on the bed. I squeezed in between the bed and the patient so they don't fall in and just help hold them. You know, sometimes you have to be that person in between the injury, which would have been the wall. All right. And then falls. Despite appropriate assistance and care, sometimes people still fall because gravity is our number one enemy. Whether it's for your boobs, whether it's for your face, whether it's falling down and breaking your patella, gravity is the root evil of it all. You will remember that. We still have to minimize the physical impact of the fall to the extent possible. And this is why we teach you how to help them fall to the floor. You would rather take that injury than your patient. And I know it sucks, but if I'm going to get injured taking down a patient, my workman's comp is going to come me. And I don't care what they want to say because I'll be like, we're going to have a conversation.
Like, I'm about to say every fall is.
No, let's not run up behind some ladies. But they still have, like if somebody falls in the patient waiting area, you have to call a code, right? They have to be assessed. There's a whole list of things that has to happen. They have to be assessed for injury. They have to be offered to the emergency room, blah, 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 blah. Because I guarantee you, if they say, oh no, I'm fine, they will walk out and go, I think I need to go to the emergency room.
Have you heard about that thing where they get like my grandma used to say that you get a chihuahua whenever you have seizures and it like passes it on for the dog. And you know, it's funny because like, I mean, it doesn't have to be a chihuahua, I guess, but she would say chihuahua. But like my cousin had bad seizures and he stayed with my aunt for a while and they had a Labrador who would go sit in front of his door.
No, dogs are sensitive.
And she started getting seizures like, yeah, it was weird.
Well, no, that's a communicable disease. Anyways, we also need to be aware of wounds. Somebody comes in with some gunshot wounds, stabbing wounds. Things happen to people, right? And sometimes it's not pretty. And this isn't Detroit, but it happens. So if you have, if you notice blood coming out of an already dressed wound, please, for the love of all that's holy, make sure that nurse, when you properly hand off, is aware of the issue. We got some extra bleeding going on. It shouldn't be happening like that, okay? I only put in here burns because maybe you'll see it, I don't know. And something called dehiscence, like you're gonna have a wound that's gonna open up on you. I hope not, but that's what that is when a wound dehisces, it will open back up.
My dad, he had stomach surgery, and my sister's a nurse. He called my sister, hey, I need you to come to the house. and his guts were like, he
Hanging
was
out.
holding on to them.
I've actually seen people in the ICU like that because of the type of injury that they had. They couldn't close the abdominal muscles, and what they did was put in an abdominal binder. So every couple of days, they would go in and clean them out and tighten the binder until the skin could be closed over the injury.
He had,
So it's crazy what kind of surgeries we can do.
it looked like bungee cords.
Mhm.
Yeah, it was like,
Yeah, that's internal sutures that they close together. Yeah, surgery is awesome. Anyways, that's it. But here's the crux of it. What I wanted to say, in high school, I had a Latin teacher. She was scary lady, right?
oh, that's good.
What? You're like, us too? Anyways. But how old are you in high school? Like, not an adult yet, right? Not an adult.
Like, it depends on what grade.
It depends on what grade. But here's the thing. She took an entire class period, and back then it was block periods, so it was like, what, an hour and a half? And she just stared at us for an hour and a half. And we were all like, what did we do? Nobody said anything. Nobody did anything. But the next time we had her class, she like jumped on our throats and said, I am diabetic. And if I ever get that way, somebody needs to say something, and somebody needs to get me something, and somebody needs to X, Y, Z. And I remember that so many years later because I'm like, how would you expect children to be your healthcare professional if you don't can say something? We had no idea. Absolutely no idea. And I'm like, who the you think you are?
You went back and found
I
her.
should. I think she's passed away now. But that's the realization that some people have, that you should just automatically know what's wrong with me. No, that's not the reality. We now, as healthcare professionals, just should be aware that there may be something going on that requires a little bit more investigation. Okay? Great.